Welcome to Knovva Academy. My name is Alex Krasser, and I'm head of online learning. We're very excited to present the Pandemics and Public Health Initiative designed to help teens around the world be better informed about one of the most impactful events of the modern era. The COVID-19 pandemic is an unprecedented challenge to our way of life, along with our systems of healthcare, our economies, and our systems of governance. How are different parts of the world being impacted? What unique challenges and solutions are they navigating? And who are the public health professionals working hard to get our lives back on track? To help us answer these questions, we're very fortunate to be joined today by Bhargav Krishna and Joseph Corlis, both doctoral candidates at the Harvard University T.H. Chan School of Public Health. Gentlemen, to start, I'd love it if each of you could introduce yourselves and describe a little bit of your background as it relates to our conversation.
Okay, I can go first. I am Bhargav Krishna, and I am a second-year doctoral student at the Harvard T.H. School of Public Health. Prior to my joining this program here, I've worked in public health for about 6 years at a nonprofit in India called the Public Health Foundation of India, where I help them with work on universal health coverage, as well as on environmental health, including issues like air pollution and climate change and how it affects health.
Hi, everybody. I'm Joseph Corlis. I work mostly with development assistance in health programs. I have worked at several different nonprofit organizations based in Washington, D.C., as well as the United States Peace Corps. And a research institution in Brazil.
All right, cool. So what sparked your interest in public health? What led you to where you are in your studies today?
So after college, I still had no idea what I wanted to do when I grew up. So I joined a public service program called the Peace Corps, and I lived in a village in the Republic of Niger for 2 years. The community where I lived asked for help with several health programs, and that's where I learned that health really matters to everybody, rich, poor, young, old, my neighbors in North Carolina, my neighbors in Niger.
Bhargav, how about you?
So I am a somewhat accidental entrant into public health. I'd always worked on issues that were kind of adjacent to public health. I'm trained in biotechnology and then in environmental science, and I've done work that was sort of related to public health in both of those fields. I ended up taking a job at the Public Health Foundation of India in 2013, which kind of drew me into public health because I was working at this interface of how environment affects health, which was growing in India at that time as a field of inquiry. And so jumped into public health as like an experiment almost to see whether I could expand my own interests. And it ended up being a rich and rewarding experience because there's so many different ways in which we experience public health in our daily lives that it was a fascinating learning process, and now I'm doing a degree on it.
All right. Well, as our students navigate what they want to do in the next steps of their lives, it sounds like following your curiosities and your passions and seeing where they lead you is a good way to go. So thank you. Do you have any heroes in the field of public health that you've met or studied or read about? And why are they your heroes?
Aside from Bhargav Krishna?
Sure.
I'll let you go first, Bhargav, if you want.
You've thrown me off there. No, I don't know if there are sort of any specific heroes that we have in public health. I think there are lots of people who have done amazing things within public health that I think we all generally look up to. Just to take examples from our own school, so there's people like Alice Hamilton, for instance, who essentially set up the field of environmental and occupational health way back in the early 1900s. Was the first woman faculty member at the medical school, was denied tenure for a number of reasons, and broke several glass ceilings, which was really exciting for me to learn about, given that I continue to work on that field now. I think in India, there are several people who work on community health, especially with marginalized populations, who are deeply inspiring. People like Dr. Abhay Bang, for instance, who runs a small nonprofit in a district in central India, which is affected by extremist violence. And he's managed to do that while improving health indicators far beyond many of the neighboring districts. These kinds of things are really inspirational.
And for me, truthfully, it's hard to name one hero, but I will tell you that something that my grandfather told me when I was a young child continues to inspire me through its applicability to public health, which is a quotation from President Truman, that it's amazing what you can accomplish when you don't care who gets the credit. I think that really sums up the nature of public health, that so many people have to contribute to something in order for it to be successful. And it's impossible for any one person to get all the credit, or very often really even a slice of the amount of credit that they actually deserve.
Well, hopefully we can give a little bit of credit today. Let's take a moment to celebrate some of the roles that you feel are most important that don't get the credit that they deserve in public health.
One of the things that's great about public health is that you can really pick anything you're passionate about, and you can make that a public health career. So if you're passionate about architecture, well, then you can help design buildings that elevate people's mental health by exposing them to sunlight and greenery. I care about a whole lot of things, and truth be told, one of them is money. And so I try to make sure that every moment of my work really focuses on making sure that people in low-income countries have access to health resources, and that they get the most value, the most health benefit from every dollar that's spent on health programs in those countries. And so really you can pick anything that you care about, and you can make that part of the public health bubble that really benefits people in your neighborhoods as well as around the world.
Yeah, no, I think that's excellent. And I think just to add to that, it's public health is such a fascinating field simply because it is so deeply influenced by everything in society, and improving your own health status can have such an important knock-on effect on all of the experiences that you have in life, whether it be on income, whether it be on access to essential services. All of those things are influenced by your own health status as well. I think just to add to what Joseph also said, I think the creativity that you can sort of express within public health research and practice is really limitless. I think we've had, I teach a class of undergraduate students right now, and I think they've had some of the most creative ideas I've seen on how to address issues of opioid abuse, or how to address issues of trade and how it affects public health, women's violence, how to address issues of, well, other things as well. But yeah, a bunch of these things are very closely linked to public health, but are outside the domain traditionally of the health system. But the public health research and practice field provides you the opportunity to work on all of these issues.
So both of you have worked in many different parts of the world, and I'm very curious how your experiences in these different parts of the world have compared.
So Joseph may have much more to add on this. I've only worked in like a couple of countries. I've only worked in India and in the US, and sort of distantly with regard to work that's been done in other countries around the world, primarily through setting standards and things like that. I will say, I think the sort of commonalities between all countries is that there are groups that are vastly disadvantaged by not having access to essential health services, and that is a common theme regardless of where you are. Inequalities play out in many different ways in different parts of the world, but one way in which they're common is in access to healthcare and essential services related to health. I've seen that regardless of which country I've visited or worked in, and it's an area that requires sort of deep insight and inquiry as to think about how do we go about fixing this complex issue.
I think that your question is really a question of resources and of preferences. There are some global standards in things like care and program design. For example, vaccination schedules are pretty standardized. The air quality metrics that Bhargav works with so frequently, those are standards. But then a lot of things depend on where you are and what local populations want. So an example, does everybody want to have a male doctor? Does the local government pay for the medical services, or do people pay out of their pockets? And so what what societies define often often has a huge impact on the way that the health system is created and functions as well.
So obviously the biggest health crisis that we're facing at the moment is the COVID-19 pandemic. And so building on the last question, I wonder if there are any unique strengths or weaknesses in the different places you've worked that you'd like to comment on vis-a-vis pandemics.
I can go first. I'll tell you that every health system around the world has really the same building blocks. It's what the World Health Organization calls the building blocks. And that's really trained staff, health services, supply chains of products and technologies, financing, data systems, and leadership. And every country has its own policies and procedures that regulate those different building blocks. And systems with good supply chains, for example, don't run out as quickly of personal protective equipment, the PPEs that you hear about in the news. Systems with low numbers of trained staff are less likely to be able to respond effectively to an epidemic. But it really depends on which country. You find that just because a country is a low income country, that doesn't necessarily mean that its health system is non-functional. In fact, some countries that you would think might not be the most developed actually have really strong aspects or specific building blocks in their health systems that are just really admirable.
Yeah, and just to add to that, I think we've encountered with this particular pandemic a very interesting challenge, right? Where Western countries, especially North America as well as in Western Europe, have borne really the brunt of the pandemic in ways that we didn't think that would be possible. Primarily because we assume intuitively that they're really advanced, they're economically quite powerful, they have really strong health systems, and from a quality perspective, maybe not from an access perspective in all of their cases. But if you look at Europe, they all have some form of universal health coverage already, but the health systems are still suffering for a variety of reasons that we did not necessarily factor into when we were thinking about how to plan for a pandemic.
Can you say a little bit more about that? Because I'd never made that connection before. Why is it that a lot of the more developed world, for lack of a better term, seems to be struggling more with the pandemic at the moment? Why is that?
A fair amount of it, I think, has to do with the age structure of the population in these countries. I think a lot of the developing countries have a much younger median age, for instance, and they have a far greater number of young people. And if there's anything we've seen from the data that's been generated from this pandemic, it's that older people are more disproportionately affected, both in terms of being infected and becoming severely diseased, as well as in terms of deaths, the number of deaths that have occurred. Countries which have had a large number of older people, or countries which have been very interconnected with the rest of the world, have been particularly affected in this case. And the US and the UK are countries that tick both of those boxes to some extent. In addition to that, these countries have also seen a focus shift away from, to some extent, universalization of healthcare towards cutting funds towards publicly funded programs and moving towards privately funded or out-of-pocket expenditure on healthcare. The UK, for instance, 2 years ago, cut a large amount of money from its NHS budget, money which would have gone to actually preparing for issues like this, including on stocking up of personal protective equipment for physicians and healthcare workers, amongst other things that would have been relevant in the current pandemic. So those are some of the ways in which it is played out right now.
And I think on top of that, you find that every country has disparities in health, as Bhargav alluded to earlier. And sadly, an epidemic like this really just exploits those existing inequalities and inequities. And you find that disproportionate numbers of people of certain groups suffer because of a lack of access to care, because of lack of insurance coverage, or just not having enough hospitals in their area, for example. And that really ends up making a huge difference during a pandemic.
Yeah, I think Michigan recently released figures related to that, which were very interesting. I think Black and Latino populations make up about 13% of the Michigan population, whereas they've disproportionately high number of deaths. So about a third of the deaths in Michigan related to COVID were Black and Latino.
And then if I can add one last piece that's really essential to note in a time like this, when a pandemic like this is being used to fuel xenophobia and xenophobic rhetoric, is that 28% of physicians in the United States are also are immigrants. You know, I think it's 19%, 17 or 19% of the entire healthcare system in the United States is people who were born outside of the United States. And so we really have a kind of a global health system here in the US. And I'd like to see us learning a lot more from other countries as a health system in order to better respond to this crisis as we go through it.
It's really well said. Thank you. So you both have referred to data a lot. And obviously when you're making important public health decisions, you need to have data with which to make those decisions. And so I'm wondering if you could talk about what sorts of information do we need to collect to make decisions, and what sorts of decisions do we need to make moving forward?
Sure, I can give that a shot. I think Bhargav and I just like all the data. We'll take it all and we'll figure out what we can from it. But I think perhaps the best answer is really in terms of what it is we're trying to do. And I think a lot of people talk about trying to reopen the country. That's an interesting sort of expression. And really, in order to do that, we do need data, but we're going to have to rely on some estimations in order to really discern three major considerations, which is what is the risk to the public that this disease poses, what is public opinion of the disease and of the current political situation, and then what is the cost. And public opinion's really measured in polls and protests and calls to government representatives. That's one that's sort of falls outside of mine and Bhargav's areas of study right now. But cost is very much within my area, and it's measured really through estimations of how much damage we think quarantine will do to the economy writ large versus how many people will die. And we use something called the value of a statistical life, which means how much the average American is willing to pay to avoid dying, which is somewhere around $9 million. And so then we just estimate how many people we think would die and what that cost would be. And we do that math. And then in terms of the actual risk to the public health, as of last night, New York City alone had more than 15,000 people die because of COVID-19. Worldwide, there have been roughly 185,000 deaths. And so the risk is there, and we don't know that it's going to go away anytime soon. And so we use data, and we have to do a lot of modeling, a lot of estimating to be able to try to fill in gaps that we don't know. But those are sort of the main buckets that data really falls under as we try to address this pandemic in real time.
Yeah, so if I were to sort of narrow the focus down just to the disease and how we understand how the disease is spreading within the community, I think in any epidemic, there are multiple stages that we look at. So the first stage is where you have identified that there is a disease, that there is an outbreak, somebody has been infected and they're likely to transmit it. The second stage is where you have transmission within just groups of people who have come into contact with somebody who has been infected. And the third case is where people have been infected without really knowing where they may have come into contact with an infected person, so we have the initial outbreak, local transmission, and community transmission of the disease. We require different kinds of data at different stages of the outbreak to try and understand how really to tailor the public health response to something like this. So in the initial outbreak, what you really saw most countries do is screen passengers who are coming from outside, because the assumption is that it's only people who are coming from outside who are probably going to be bringing the disease. The second phase, when you have local transmission, you also have to try and identify who may have been infected by people who have entered your country or who are infected themselves. And there you require something called contact tracing, where you trace all of these individuals, you isolate them, and you screen them as well for the disease. In the third phase, essentially, you're trying to do damage control. If your epidemic has reached a phase where you are unable to identify each and every individual and how they have been infected, then you're at a stage where you're trying to do damage control, and that's where you have to institute policies like stay-at-home orders or large-scale national lockdowns. And at that point, you're essentially trying to find out how many people have already been infected so that you are able to effectively judge when you can reopen your economy, because that is a different question altogether to answer.
So Bhargav, you're describing an ideal scenario where this is exactly how it should be happening. And I'm assuming seeing an attempt at that in the real world, but I've also seen a lot of articles and headlines about inaccuracy in testing or having difficulty getting an accurate sense of who has the disease, who doesn't, who's transmitting it and whatnot. So I guess, could we get a situation report on how we're doing and why it's so difficult to get accurate numbers?
Yeah, so I think the part of it is down to the fact that this kind of came out of nowhere. I don't think we were really prepared for it. The second aspect is just the nature of testing itself. No test will ever be 100% accurate. Most laboratory approved tests by the FDA are around 95% accurate when it comes to detecting false positives as well as false negatives. So the number of false positives would be 5 out of 100, or the false negatives would be 5 out of 100 if you test a large enough amount of people. Right? At this stage, we have, in the particular case of COVID, most tests which use the PCR method for COVID have a pretty high false positive rate and a pretty high false negative rate. They're sort of 3 in 10 could be false positives. And that has implications. So either you could be initially identified as a person who's been infected falsely, or you could have a false negative, and then you could be detected as a case later on. So challenges with testing go away as we become more experienced in testing for that particular disease. And as testing ramps up, we have more data to better understand how to test within a particular population. Right now, we're sort of going through all of those teething troubles as essentially within a pandemic situation, which makes it all the more difficult for scientists to kind of work on those issues.
And just to complement that, I think one of the things you're going to hear a lot about in the coming months is the word serology, which means blood testing, to help understand perhaps people who have already had the virus, who might have been asymptomatic, but whose antibodies are now able to respond to the virus effectively. And so that's going to help us understand if people are immune after they have an infection. Because there's no guarantee that people who get infected won't get infected again. In fact, coronaviruses, just to be clear, saying coronavirus is kind of like saying a dog. There are different kinds of dogs. There are different kinds of coronaviruses. SARS from 2002, 2004, that was a kind of coronavirus. COVID-19 is a kind of coronavirus. And when people got SARS in the early 2000s, they were immune for about 2 years. After 6 years, research shows that they really didn't have any antibodies left to fight SARS infections. And so we're using this testing not only to understand the current scope of how many people have the disease or have are infected actively, but also how many people have already been infected and what that really means for them beyond that period of infection if they're able to survive.
Thank you for clarifying. So you've mentioned some policies like stay-at-home policies, and I'm wondering if you can describe the process of developing a policy, especially as it relates to public health. What challenges that policy may face getting enacted, and then we'll get to pandemic-specific policies, I guess, in a follow-up question.
Sure. So we can use this particular COVID-19 issue as an example for this. So let's say the question around COVID-19 was, do we implement stay-at-home orders or do we implement lockdowns? So to answer that, we need to first understand why do we need to do these in the first place, right? And the rationale for doing that is because the disease is spreading at such a rapid pace within society that if we don't institute some kind of distancing measure, so many people are going to be infected over time that it would overwhelm the health system. The problem is not the number of people who are getting sick because of the disease, it's the number of people who are getting sick in such a short amount of time. And that's where it becomes a problem for the health system to deal with. And so the goal of this measure, in this case, social or physical distancing or whatever you'd like to call it, is to try and reduce or break the chain of transmission. So people staying at home means that they can't go out and infect other people or be infected themselves. The implication of that is you're essentially shutting down large parts of the economy. And now we're seeing projections from international organizations that you're probably going to have negative growth for this quarter for many economies around the world, or flat growth or virtually no growth for some other developing economies. What are the trade-offs that you factor into a situation like that is a really tough question to answer. I think in this case, it's a question of, do you want 100,000 people to die or do you want 5 million people to die? And it goes back to questions like Joseph raised initially, which was around what is the value of a life and what is the value of statistical life? You overwhelm your health system. You may lose large numbers of healthcare professionals as well, because that's where most people are getting infected, or rather there are really high infection rates, especially for people who are working within the health system. What happens then? Do you bear the burden of that as a society? The goal of each one of these policies is to do it in a slow manner, or rather roll out the infection in a slow manner so that you reach herd immunity without overwhelming your health systems. And herd immunity means you've reached a phase where each person is not infecting more than one other person, which means that you're not going to have a disease that is highly contagious. Some countries are trying this policy of, okay, we initially will keep everything open and let's hope for the best with herd immunity. The UK tried that and now suffering the consequences of it. Other countries initially went straight away for sort of policies where you isolate all cases and do extensive contact tracing and try and identify anybody who may have come into contact with that individual. South Korea is an example of that. They've had great success. They didn't have to institute this kind of mass lockdown mechanism in their state because they did all of these things in advance. So it's a question of how you plan, how you execute, and whether these trade-offs, many of these trade-offs only come into the question because you haven't done preparatory work in advance, or your health system is incapable of dealing with initial stages of an outbreak well.
So I'm a little hung up on this idea of putting a dollar value to a human life.
Oh, geez.
I'm sure many of our students are as well.
Sure.
You guys have had a little more time to process this idea, and so I was wondering if you could sort of help us process it.
Okay. Let me dive into that, Bhargav, since I brought up in the first place. I did not bring it up to shock you. It's something that's existed for decades. A lot of political policies and laws get enacted, regulations get enacted because of this value. And presently, this value of statistical life is actually helping us understand that social distancing is, in the long run, a far better investment than opening the economy right away and letting a lot of people die.
So if I can just add to that, I think the idea of valuing life in that way sounds absurd to most of us, including myself. I think it's a ridiculous concept in some ways, but I think it's a concept that came about because economists had to put a number on things and because economists had to justify why you institute certain policies over others. But the reality is the people who are either valuing these lives or who are making those decisions are usually not those that are ever going to have to face the consequences of those decisions themselves. So there's a lot of things that you sort of pack into something like this. Metrics have a whole history behind them, and I think it's a useful tool when you're having to make decisions which are hard or which are on the fly. But I think there's a lot of context that goes behind it.
Yeah, I think the best way to think about it is not that economists are trying to be, really unfeeling, and say that a person is only worth X amount of dollars, but it's trying to say what is the contribution that this person might make to society? What is the value that this person might yield beyond an economic contribution? And how can we quantify that in a way that helps us make decisions of what it really means if that person is lost to us? It's really just a tool that people use as part of a decision-making process to understand what the economic impact of a particular policy might be. For example, requiring that airbags or seatbelts be installed in every car comes at a cost to the companies that produce cars. It comes at a cost to the people that need a car from the assembly line. But it also represents great improvements for society because we don't let a lot of people die. We're able to protect them better with these advances. And so the value of a statistical life is used very, hopefully very positively to help us make the right decision so that we have the healthiest population possible. And in the context of COVID-19, where 2 or 3% of the population might die from this virus, we really want to make sure that it's clear to decision makers that the value of those lives, if we talk about a humongous country like the United States with almost 400 million people in it, 3 to 4% represents an enormous figure, and it outweighs the current losses that the economy is bearing because of things like social distancing. And so we're able to use the value of a statistical life in order to help preserve people's health. And this is a value that's able to help us show that presently know that the risk that we might lose that many people would have a bigger impact on our society, and that social distancing is actually a more fiscally responsible, as well as perhaps a more moral decision to make.
So obviously there are a number of factors to consider when evaluating how to improve public health. And I know that an area that Bhargav, you specifically have studied is air quality and air pollution. So I was sort of wondering if you could talk about the intersection of environmental health and public health and COVID-19 and all that.
Sure. No, that's perfect. I think there's lots of areas in which environmental health intersects with this, right? I think the most direct way in which we've observed it is as a byproduct of all of the social distancing measures that have been implemented around the world. The city where I'm from, for instance, Delhi, which is one of the most polluted in the world, has had blue skies for like 2 weeks in a row, which is crazy. We've never seen that before. So but the reality behind that is that you've essentially had to shut down society to get to that place. What it also shows for those of us who are working on the issue is that with effective action, we can actually have those things, those good things that we all really want, which like clean air to breathe. We can have all those things if we implement policies effectively. From the perspective of how air pollution has affected COVID, colleagues from our own school have published work in a journal recently, which talks about how differential air pollution exposure in different parts of the US has really affected the case numbers. So parts of the US which have higher levels of air pollution have had higher levels of COVID cases as well. So there are some correlations that we definitely need to explore further. From a purely sort of mechanistic perspective, we know that air pollution affects the lungs quite deeply, and I think COVID, naturally being a respiratory illness, is something that is going to affect people who have deficient or weaker lungs. We've already seen that as well with people who are smokers or who vape. They have also been particularly susceptible. So it's a natural conclusion to draw that people who are exposed to higher levels of air pollution before are more likely to suffer sort of severe disease when it comes to COVID.
It's hard to imagine right now, but I know there is going to be an after the COVID-19 pandemic. And I wonder if this is going to be a big question, and I apologize, but what might after COVID-19 look like? And if you wanted something more specific to answer, what lessons do you think we will have learned from this pandemic that we will apply to public health moving forward?
I can take a stab at what the after might look like. I think it's going to take a while for us as a country and as a world to really return to normal, what we thought of as normal beforehand. There will for sure be an after, so all hope is not lost. But I think it's going to take us a while. When I was in Guinea during the Ebola outbreak, I saw that trust is something that takes a while to rebuild. Especially during a pandemic, trust that your neighbor is not going to get you sick. Trust that the government is telling you the truth. I think the average person really wants to be healthy and productive. And so in the after, I think that it's going to just be incumbent on policymakers and public health experts to really lead the way in showing people how can we best be productive while staying healthy, because I think that there's going to be a phased entrance into after. I don't think that it's going to happen all at once, and I think that we're going to have to gradually shift our way to the after, and hopefully it's something that we come out of with a lot of lessons for how to best invest in our public health systems so that we maybe don't get caught by surprise by something like this in the future, because we had movies about threats like COVID-19 for years before this actually happened. And so it's not beyond our imagination that something like this might happen. And it just takes people not losing enthusiasm in making sure that we can be healthy and we can be productive in order to make the investments that we might need in our health systems to guarantee that something like this, something like social distancing, that I don't know that many people are enjoying very much, doesn't have to happen in future pandemics.
Very good. I think just to add to the trust issue, I think one of the big breakdowns that we have observed during this pandemic is this rise of xenophobia. And I can speak to India. I think there has been a villainization of specific ethnic groups or religious communities, which has been extremely counterproductive, because not only do you take focus away from the larger issues that you're trying to tackle, but you also stigmatize individuals from those communities from ever wanting to come and be tested themselves, which then means that they may go and infect others. To your bigger question around what happens once this is over, I think we need to also consider how does this end, right? And there's two ways that this ends. One is each of these countries reaches herd immunity, which, as we've seen and we've heard from researchers around the world, it could take a year, 2 years, anywhere between 6 months to 2 years, depending on where you are in the world. The second way that we end this is by developing and distributing at scale a vaccine that could address this issue. There are several vaccine trials underway, including one that's administered by the World Health Organization itself, which involves several dozen countries around the world. Again, once a vaccine is invented, the question of where do we try this out first and who gets the vaccine first when it's at production, all of these ethical questions come into the picture. And so we don't know how long it will take for everybody in the world to be administered this vaccine. So all of these questions are sort of huge question marks that we don't have answers to right now. Once this is over, I hope that this is kind of a wake-up call to politicians around the world that you can't continually keep cutting funds from public funds for healthcare and expect that the health system is capable of responding to urgent and rapidly growing threats like pandemics like this. If there's anything that we've learned from the experiences of countries which have dealt with this well, countries or even provinces within countries that have dealt with this well, it is that you need to invest in primary care. And by primary care, we mean local physicians who are dealing with smaller populations, who have a large group of frontline health workers who are able to go out and test in the community, who build strong relationships within those communities so that you're able to deal with this when the outbreak first starts, not once it's gone out of hand. The larger questions around society, how it would reorder itself, all of those things we're seeing playing out already. I think China is really the production capital of the world for most of these things that we're dealing with right now, whether it be personal protective equipment, whether it be testing reagents that we need to test for COVID, whether it be pharmaceuticals that we need, all of the active pharmaceutical ingredients, over 85% of them are produced in China. We may see a reordering of how all of these things that contribute to the health system are onshored more than they were before. We live in a globalized economy. Pandemic like this has implications for everybody, right? How do you deal with those kinds of things? I think there's larger questions that will kind of play out over the next decade or so, which I don't know we are capable of even remotely answering.
Well, thank you for attempting to. And it's been fascinating to explore this challenge with you. So as we wrap up, I wanted to know if you had any additional thoughts that you'd like to share with our student community. Any parting thoughts or words of wisdom?
Mine is really simple. Just be nice to people. You know, a lot of people are trying really hard in this time. Yesterday, I had food delivered by a guy who'd been working for 9 hours delivering food just so that people like me could stay at home and be safer. And so, you know, yelling at people because the grocery store doesn't have your favorite scent of soap or flavor of Pop-Tarts doesn't do anybody any good in this time. And I think that that's something everybody can do right now. If you want to become a public health professional, there's absolutely space for you. And we think that you know, everybody adds something to our field. And so Bhargav and I know would love that as well. But being nice today really does have an impact.
Yeah, I think that's very well said. I think just the way that society has sort of been defined over the last few years is by crazy partisan vitriol. I think it's more important than ever for us to kind of recognize this importance of being kind to each other and to recognize the importance of essential workers in various parts of society. I think whether it be healthcare professionals, whether it be folks who work in grocery stores, whether it be delivery persons, whether it be all of these public transport professionals, whether it be people working as firemen or cops or all of these different professions are essential for a well-ordered society to run effectively. And I think we do a bad job in recognizing those things in good times, and in bad times we put even more pressure on them in some ways. And so we not only have to be kind to them, we also have to be kind to ourselves during these difficult times. I think all of us are dealing with a kind of unprecedented challenge, and there's so many mental health effects that accrue as a result of these things. And so be good to yourselves, be kind to yourselves. That's as much as we can ask for, I think.
We've only had COVID-19 for less than 6 months, and we've already achieved a lot. Like, normally creating a vaccine takes over a decade. And we already have vaccine trials underway. We've mapped the entire genome of the virus. We've got countries that never share public health data talking to each other continually. I mean, public health has really responded to this, and it's still a crisis. It's still very hard, but I think that people like Bhargav, people at our school and elsewhere, they're really doing a lot to try to curtail the effects of this virus for everyone.
That's great, guys. Thank you so much. It's great to see, it's great to have a window opened up into the field of public health, into the ways that you guys are thinking about the world and the challenges we face. So thank you so much for taking the time to speak with us today.